Spain, where he's working. He's an MD and working on his PhD, as far as I understand. And I think you're going to give us a little bit more information on the clinical experience with this device, with a special focus on men with acquired and non-acquired premature ejaculation. Welcome.
Hello. First, sorry for my fluency on English. I don't speak foreign language like my teammate. I would like to send to the key invitation from Dr. Sato in representation of Japanese Society for Sexual Medicine to be in this event. Thank you very much. The aim of this presentation is to show a new exercise program we have successfully used it in Spain in the last 3 years with men who had premature ejaculation, for which we have used a masturbation aid device produced by Tenga company, Japanese company who designed an innovative masturbation device. Premature ejaculation is considered the most frequently reported male sexual dysfunction and affects several millions of men worldwide. Diagnosis of PE is essentially based on the patient's medical and sexual history. The exact cause of PE are still considered unclear. Treatment for PE include a combination of pharmacological and psychological approach, especially cognitive behavior technique for the man and his partner. Major guidelines recommended drug therapy as a first-line choice. The use of selective serotonin reuptake inhibitors, daily dose or on-demand, and on second line, the use of topical anesthetics, PDE5 inhibitor, and alpha-adrenergic antagonists. In the last year also, there is indication for the use of psychological treatment in combination with pharmacological treatment in acquired premature ejaculation. Although clinical data with pharmacological treatment in major guidelines suggests that the level of adverse effects is acceptable for the benefit derived in the patient with PE, their pharmacokinetic profile and pharmacodynamic activity result in a huge limitation we're using for treating PE. You can see with antidepressant off-label treatment, 60% patients refuse or discontinue treatment. With dapoxetine, the only treatment approved in some countries for treat premature ejaculation, 90% patients refuse or discontinue treatment. In order to psychological treatment, I really believe that psychotherapy offers men, women, and couple benefit. But nowadays, sex therapy is an amalgam of different techniques, and the majority of psychotherapy treatment outcome studies are uncontrolled, unblinded trials, and few meet the requirements for evidence-based studies also. I mean, future well-designed studies on the efficacy of psychotherapy are needed. Also, we need a standard protocol of treatment, psychological treatment. In 2014, we launched a national campaign against premature ejaculation named I Control, Yo Controlo. This campaign included an annual research accompanied by information on internet sites and adverts discussing premature ejaculation in mass media. Until now, we have published 2 articles of case series in international journal with effects on an exercise training program using a masturbation aid device to improve the control over ejaculation. And now, this year, we are developing a new research with a group control. For this last research, we are using the last version of this training program, version 3.0. This last version of exercise training program has been developed after 3 years of joint research between the Sexology Institute of Murcia, a Spanish health center specialized in sexual dysfunction, and the Japanese multinational Tenga. With this exercise program, for which we use the Japanese device called Fleet Zero, we intend to provide a better understanding of the ejaculatory response as well as to increase control of it, which is essential in losing the fear of ejaculating quickly and therefore attaining more adjusted ejaculatory time. This exercise program is an adaptation of a method of treatment for PE published in 1956 in the Southern Medical Journal by the urologist Dr. James H. Simmons. The 7 weeks of exercise are aimed at increased control of ejaculation. The patient learns to decide when to ejaculate, so that the time of ejaculation will no longer be a problem. You can see, first week, we have an exercise called Discover Your Pelvic Floor. In this exercise, we educate to the patient, and the patient intends to raise awareness of the ejaculatory response, identify the tension on the muscle on the genital area, especially in the pelvic floor. Next week, we have an exercise to take the control over the pelvic floor. In this case, we use a start and stop to identify the tension and try to reduce this tension, with a special attention in the anal sphincter. Next week, 5 and 6, we make an exercise to delay ejaculation using pelvic floor. In this case, we don't make a start-stop. The patient has to loosen the tension in the genital area and relaxing the anal sphincter, and not to stop, in this case, stop the ejaculating reflex. Last week, we made another exercise for control the pelvic floor, but with a movement very similar to penetration. On December 2014, we included the control training program version 1.0 with masturbation aid device in the protocol of treatment of PE in our clinic in Spain. More than 700 patients have used version of this program in the last 3 years. The combination of paroxetine 20 mg daily dose and the control training program showed the best results. 231 patients have used only control training program. From this patient, clinical benefit in control over ejaculation during sexual intercourse was 83%. In reduction in ejaculation distress and interpersonal difficulty were both 62%. The last version of this program has been developed on 2016 version 3.0 that include online program treatment and a mobile app. Combining paroxetine and program training harnesses the power of both therapies, provides patients with rapid symptom amelioration, while the man gains the skill to take control over ejaculation with this exercise. This combination reduces PE recurrence. With this program of exercise, the inclusion of the partner in the treatment process is not necessary. Many patients, haven't got a stable relationship or are reluctant to include the couple in treatment. The training program also using a masturbation aid device who lacks side effects, and it is a good option for patients who refuse or do not respond to typical antidepressant or another medication. Next version, 2070, won't be necessary to come to the consultation of a specialist for its use. Thank you very much for your attention.
Thank you very much. Are there any questions from the floor? Can you go to the mic, please? And please identify yourself.
Hi, I'm Mohammed Shamsul Hassan from Bangladesh. I was wondering, paroxetine itself has got the highest IELT in response to PE. And also you're using the start and stop technique and the other year. So how the wellness product is helping as you are combining paroxetine, you are giving the start and stop technique and everything.
Very good question. The first article in 1956 from urology Dr. Seaman said that his program could be improved if the condition of the training will be more similar than intercourse. With this device, the training is more similar than stimulation that you receive in an intercourse. The stimulation of the glands is very similar. With masturbation, sometimes you don't stimulate the glands of the penis. With this device that use a lubricant and also stimulate a lot the penis. Now, our last research, we have a group control that made the exercise and other group with exercise and device. We want to compare the improve the result with the device, but the first idea was that the device is more similar than the intercourse to make the exercise. It's better. When we have many patients that don't suffer premature ejaculation with masturbation. They have only premature ejaculation with sexual intercourse. But when they use the device, the latency ejaculatory time decreases. It's more stimulation. This is the reason.
I'm going to ask my question again to you. You have the clinical experience. In my clinic, a lot of men do not want to masturbate, maybe for cultural or religious reasons. So what is your experience with this device? Because that's a problem if you introduce start-stop technique and they say, I can't do that, and they don't do it.
It's a very good question. In Spain, it's the same. People older than 15 years old doesn't like masturbate. We have several problems to introduce this treatment, refuse this treatment. But this treatment is very comfortable for people less than 40 years old. But people with a long relationship, stable relationship, or older than 50 years old, it's very difficult to introduce this treatment. But they doesn't like masturbate. We use first line paroxetine, but when they see that paroxetine is not good, if there is no result, they accept it to prove the treatment. But it's right, many patients discontinue the treatment for the masturbation.
Okay. Amra, is that a comment to that?
Yes.
I saw you wanted to say something before too.
Yes, okay, it's the same.
Can you make it short,
This
please?
is Amr al-Maliki, okay, from Egypt. I've been practicing in Egypt and in Saudi Arabia for a long time, and I've been met with the people that believe that masturbation is harmful, okay, whether due to religious thinking or to misconceptions about masturbation. I've been explaining a lot to my patients, and really when they know the truth that masturbation does not cause infertility and it does not cause sexual dysfunction, the image change a lot, okay? I think it's not mostly religious, no, it's that they have deep in mind that this will cause them harm. So they need to be counseled properly from the physicians.
It's very important you have a educational session with the patient to explain that this is a medical treatment and it's for health. But you are right, it's very difficult with, we live in the south of Spain. The mentality is very close about masturbation, and we have to spend a lot of time to convince the patient to masturbate. But the other solution is worse, because many patients refuse pills, the antidepressant. But it's a hard job to convince the patient to use this kind of device.
Thank
you.
You.
Are right.
Thank you very much, and thank you for a very nice talk. Thank you. Then it's a pleasure.